right, welcome to our explainer on pediatric renal disorders. If you're a nursing student, this is the kind of core knowledge you're going to use all the time. We have a ton to get through, so let's just jump right in.
So let's start with a big picture question, right? Why don't kidney problems just, stay in the kidneys? Getting a handle on this concept is absolutely key to your entire pediatric assessment.
Well, it's because the kidneys are the master regulators of pretty much everything: fluid, waste, electrolytes. So when they start to struggle, you see this massive ripple effect. Fluid overload puts a huge strain on the heart and lungs. Waste builds up, making kids feel sick, not want to eat, and that can lead to failure to thrive. And here's a really cool clinical pearl for you. The kidneys and the ears actually develop at the exact same time in the womb. So if you see a newborn with funny-looking or low-set ears, that's a huge red flag to go looking for kidney problems. See? It's all connected.
So here's our game plan for today. We're going to start with the absolute basics of assessment. Then we'll get into some common infections, solve the tricky puzzle of glomerular diseases, tackle a couple of really severe systemic conditions, and then we'll wrap it all up with kidney failure. First up, let's talk about the bedrock of all your nursing care, the initial assessment. Honestly, getting this right from the jump is non-negotiable. These are the numbers you have to know, like inside and out. For your analysis, if you see anything other than negative for protein, nitrates, or leukocyte esterase, alarm bells should be ringing. And for blood work, yeah, BUN is important, but your true north for kidney function is always going to be creatinine. Why? Because it gives you a much clearer picture of the glomerular filtration rate and isn't as easily thrown off by things like diet or dehydration.
Okay, now let's pivot and talk about two of the most common troublemakers you're going to see in pediatric renal care: UTIs and something called VUR. UTIs are a huge deal in peds, especially for kids who are body training. But here's the key takeaway for you. In an infant, sometimes the only sign of a really serious UTI is a fever with no other source. That's it. And that's exactly why a urinalysis is a standard part of a fever workup for a baby. So you might be wondering, why do some kids get UTIs over and over again? Well, a lot of the time, the real culprit is VUR. Think of it like a plumbing problem. Instead of urine flowing out a one-way street, it actually flows backward from the bladder up toward the kidneys. This creates the perfect swampy environment for bacteria to grow. And over time, all those infections can lead to permanent scarring and damage. And this is how we find out for sure what's going on. What you're looking at here is an image from a VCUG. What we do is we put a special contrast dye into the bladder with a catheter, and then we take x-rays while the kiddo is peeing. You can literally see the dye going the wrong way, right up the ureter. That confirms the reflex. So what's your job in all of this? Well, your nursing care plan really has two main goals. You got to put out the current fire, and you have to prevent future ones. So that means giving antibiotics and pushing fluids for the active infection, but just as important is all that family education on prevention, teaching proper wiping, why you should avoid irritants like bubble baths, and encouraging kids not to hold their pee. And of course, with any renal patient, you're going to be tracking that intake and output like a hawk. Okay, let's zoom in a little deeper, right down to the kidney's main filtering unit, the glomerulus. We need to untangle the puzzle of two very different syndromes that can actually look kind of similar at first: nephrotic syndrome and glomerulonephritis. So both of these conditions mess with the glomeruli, but the way they do it and what they look like clinically are totally different. As a nurse, you have got to be able to tell them apart. So, how do you do it?
This slide just lays it out so well. The best way to think about it is this. Glomerulonephritis is mostly an inflammatory problem, something that happens after an infection, and it leads to high blood pressure and blood in the urine. Nephrotic syndrome, on the other hand, is a permeability problem. The filter gets super leaky, causing a massive loss of protein and really severe swelling. Let's break each one down.
With nephrotic syndrome, the whole story is about protein. The filter in the glomerulus basically springs this giant leak, and protein, especially albumin, just pours out into the urine. Well, without enough albumin in the blood to hold fluid inside the blood vessels, that fluid escapes into the tissues, and that's what causes that classic puffy, all-over edema. This edema mnemonic here is a really fantastic way to lock in those key features. Now, for glomerulonephritis, the key word you need to remember is inflammation. The classic story goes like this.
A kid has strep throat, and then a couple of weeks later, their own immune system gets confused and starts attacking the glomeruli. This inflammation clogs up the filter, which leads to fluid backing up, blood pressure going way up, and red blood cells leaking into the urine, which gives it that classic tea or cola color.
Okay, now let's zoom back out and talk about two conditions where the kidneys get caught in the crossfire of a much bigger body-wide problem: Hennig-Schönlein purpura and hemolytic uremic syndrome.
So first up is HSP. This is a type of vasculitis, which is just a fancy word for inflammation of the small blood vessels. Basically, the immune system causes these antibodies to get stuck in the blood vessel walls, which makes them leaky. And that leads to this classic group of 4 symptoms, which the mnemonic CHAP helps you remember: crampy abdominal pain, hematuria, because the kidneys are involved, arthralgia, which is joint pain, and a palpable purpuric rash, usually on the legs and butt. Your nursing care here is all about support, controlling pain, monitoring blood pressure, and watching that urinalysis very, very closely.
Okay, next is HUS, and I want to be clear, this one is an emergency. It usually kicks off after a nasty E. coli infection, maybe from some contaminated food. The toxins that the bacteria release are like tiny little shredders that just destroy red blood cells. The broken pieces of these cells then create a massive traffic jam in the kidney's tiny blood vessels. This is what causes that classic triad of symptoms: hemolytic anemia from the shredded red blood cells, thrombocytopenia because the platelets get all used up in the clots, and acute kidney injury because the filters are totally clogged. These kids are incredibly sick and need intensive care fast.
And finally, let's talk about what happens when kidney function really takes a nosedive, leading to either acute kidney injury or chronic kidney disease. Think about the difference like this. Acute kidney injury, or AKI, is like a sudden, massive pileup on the highway. It just happens, often because of something like severe dehydration. But if you can clear the cause of the accident, you can usually get traffic moving again. Now, chronic kidney disease, or CKD, is more like the highway slowly losing lanes over many years because of a structural problem, like a congenital birth defect. The loss of function is slow, it's progressive, and it's permanent.
With AKI, when you're doing your assessment, you'll often find a history of some major fluid loss. The most dramatic sign you'll see is a sudden stop in urine output, either very little, which is oliguria, or none at all. The labs will shoot through the roof. But your number one most urgent concern is hyperkalemia, high potassium. This is not just a number on a lab sheet. High potassium can completely destabilize the heart's electrical system and cause deadly arrhythmias. This is an act now kind of situation. So when the kidneys finally fail, dialysis becomes the treatment that keeps the patient alive. On the left here, you can see hemodialysis, which uses a big machine as an artificial kidney outside the body. And on the right, that's peritoneal dialysis, which is really clever. It uses the body's own lining of the abdomen as a natural filter. A massive part of your job here is education, especially with PD, because you're the one who's going to empower these families to manage this incredibly complex, life-saving therapy at home.
So after all of this, all the pathophysiology, all the labs, all these complicated syndromes, what is the single most powerful tool that you, the nurse, bring to the bedside for these kids?
It's you. It really is. It's your sharp assessment skills that are going to catch that tiny rise in blood pressure or that slight drop in urine output before it turns into a full-blown crisis. And it's your clear, compassionate teaching that gives a terrified family the power to manage their child's care with confidence. In pediatric renal nursing, you are the most important intervention there is.